Aloha, I'm Dr. Pat Blanchette, Professor Emeritus of Geriatric Medicine for the John A. Burns School of Medicine, and also the founding chair of its Department of Geriatric Medicine. I'm now the Associate Director for Administration and Chief Operating Officer of the UH Cancer Center. Today we're going to be talking about the difference between normal aging and certain things that can happen to the brain that cause dysfunction. The important thing to know is that with aging, the brain and the brain's abilities should stay normal or nearly normal. And when it doesn't, something's wrong. When we talk about functions of the brain, we can talk about different things that are used, that the brain can do, and that are used to test these things and to look at the way the brain is functioning. The first thing we talk about is orientation. In other words, if you know where you are in time and place, and you can find your way around in a new place, a place you've never been before, that's a task called orientation, and the brain allows us to do that. Another task of the brain is to be able to focus or pay attention to something, and the brain allows us to do that. While orientation is usually normally preserved with aging, and the ability to pay attention are normally preserved, some people find that paying attention to more things at once, or being able to have the attention divided, in other words, you're working on something and then you're interrupted, and the ability to go right back to what you were doing before you're interrupted may decline with age. But different researchers have reported on this very inconsistently. The brain also does something called naming. In other words, coming up with the right name for something or a person's name. Now, it's possible that with aging, this declines a bit, but not very much. And we all have difficulty with naming when we're tired. When it comes to memory, there's an awful lot of discussion about whether changes in memory are normal with aging. But with normal aging, memory stays pretty much intact. It's just that you have many more things to remember because you've lived a long time. I wanted to discuss with you something that you might have heard about called mild cognitive impairment, or MCI. At one time, it was thought that MCI is normal with advancing age. In other words, people can be forgetful, and it doesn't really mean much of anything. But now we know that about half of the people who have MCI within 5 years go on to have a real Alzheimer's type dementia. So what does that mean? It means that memory and the brain's function and brain's other functions are normally fairly well retained during the 100 years or so we might use those functions. So when we look at people who have various kinds of illnesses, various kinds of problems, we realize that this is not normal. It's not inevitable that as people get older, they're going to have these kinds of changes. But unfortunately, as people get older, sometimes they get certain conditions or diseases, and I wanted to discuss with you some of the differences between normal aging and the effects of disease. The first topic we talk about is that of cognitive reserve. In other words, your brain will stay healthier longer if you made a healthier brain to start with, if you have more reserve. And what does that mean? How do you get a better cognitive reserve? Let's take a look at the way the brain is structured. First of all, the active cells in the brain are called neurons, the ones that allow us to do things, that allow us to control the actions and the abilities of the brain to allow us to function. There are lots of other cells in the brain, but those mainly support cells to the cells we call the neurons. Now, the way that the neurons are put together, You have a cell body, and you have dendrites. Those are usually receiving messages from other neurons. And then you have axons, and those are usually, that's usually the projection from the cell body that gives a message to the next neuron. And that message can be either excitatory, it causes it to do something, or calming, it might cause it to quiet down. The idea of cognitive reserve is that the greater number of dendrites that you have makes for a richer cell network. It's a difference between, for example, a tree with lots of branches and lots of big branches and lots of little branches, and a very healthy looking tree compared to one that wasn't very healthy in its growth and it only has a few branches. The more branches you have, the less likely that you will have a great deal of decline in old age. So you want to make that healthy series of nerve cells. The nerve cells, or the neurons together, form various pathways in the brain. And the different neurons make different kinds of chemicals called neurochemicals that are the way that one neuron sends a message to the other one and creates those pathways through the brain. So when we talk about growing a healthier brain, we're talking about good nutrition at every stage in life. Now, I'm a geriatric medicine specialist. I'm interested primarily in the care of older people. So why am I talking about nutrition at every stage in life? Even prenatal nutrition. A pregnant woman needs good nutrition in order so that her baby develops a healthy brain. And that baby, once it's born, needs good nutrition so that as the brain continues to develop over the next few years, a healthier brain is being made. Then we talked about the pathways, the dendrites and the pathways and the neurons that form ways in which one neuron talks to the other neuron. Education and self-education are ways in which the much healthier brain is made. Lots of those branches that we talked about, so the neurons can talk to each other more efficiently. One of the ways that people can work towards making a healthier brain through their whole life is something we call mental exercise, doing things that stretch your mental capacity. And people talk about doing puzzles, crosswords, learning new things, learning new languages, doing things that stretch your ability to do something new, all the while you're making new pathways in your brain to make that brain healthier. That's why we talk about brain exercise, doing those things that make your brain healthier. Now, unfortunately, we're going to talk about some things that are not normal, but are unfortunately common, and they're related to age. They certainly can occur at any age, but they occur most often as a person gets older. These are not normal. They may be common, but they're not normal. One of the things that can go wrong is a stroke. We know that there's at least two different types of stroke. One that is a stroke caused by a blood clot that goes to the brain and plugs up a major artery or small artery and causes the brain around that plug to not work the way it should. And around that plug or that clot that goes to the brain, when it first occurs, there's a lot of swelling. And as a person may recover from that stroke, the swelling goes down. So the incapacity that first occurs as a result of the stroke is usually much less as time goes by, where the swelling is reduced, and also as people are assisted in recovery through occupational therapy, physical therapy, perhaps speech therapy, so that the functions that they may have lost in the acute stages of the stroke are recovered to the extent possible. Many people have had strokes And you can't tell later. They've had a lot of help through the treatment and the recovery so that they go on to fully recover. But then you want to know, why did this person have a stroke, and can we prevent them from having future strokes? A different type of stroke is called a hemorrhagic stroke, and that's when one of the little blood vessels bursts in the brain and you get blood in the brain tissue and instead of in the blood vessel. And that's extremely irritating to the brain, and those people have a really hard time with their initial treatment and with their recovery. So let's take a look at some of the ways in which stroke might be prevented. The first thing we usually talk about is controlling blood pressure. Both systolic and diastolic blood pressure are very important. What does that mean? When you hear that a person's blood pressure is 140/90, 140 is a systolic blood pressure and 90 is a diastolic blood pressure. And controlling both of those is important. We also talk about a healthy diet, decreasing obesity or avoiding obesity in the first place, and limiting salt intake so that those things can help prevent a stroke from coming on. One of the common things that you hear about to prevent stroke is controlling cholesterol or blood lipids. Sometimes when people talk about blood lipids, they become very confused because they hear the words total cholesterol and blood lipids that have different densities. What you need to think about is total cholesterol is a combination of different blood lipids, and there are certain ones that are healthy for you to have, such as high density lipids or lipoproteins, and low density lipoproteins or blood lipids, which are more dangerous for you to have in too great a percentage. And so your physician might be talking to you about, well, your LDLs are too high, or your triglycerides are too high. But the concept is there's good lipids that everyone needs, and there's bad lipids that are bad for you and that predict for you to have a lot of problems with your blood vessels. Probably the most important thing that you can do to help prevent a stroke is not to smoke. Smoking is bad for many reasons. It leads to many different types of cancer, but it also is extremely high risk for stroke if you smoke. And if you're a current smoker and you stop smoking, with every day that goes by, after you stop smoking, you're reducing your chances of a stroke. The use of alcohol is very controversial because what we do know from various good studies is that a small amount of alcohol every day seems to be good for people in terms of reducing their risk of stroke. On the other hand, too much alcohol gives you problems with high blood pressure and lots of other problems. But so a little bit is good for you, and this is not a case where if a little bit is good, a lot is better. No, this is a case of if a little bit is good, a lot is to be avoided. It's also very important to manage your blood sugar. Now, people who have elevated blood sugar have diabetes. There's two different types of diabetes, type 1 and type 2, also called insulin dependent or non-insulin dependent. There's different ways to say the same thing, or pretty much the same thing. In any event, the combination of diabetes and having a poor array of lipids that are bad for you, that combination is really bad for your blood vessels. So managing your blood sugar is also very important to help reducing stroke. There is something that is called atrial fibrillation. What the heck is that? You hear people talk about AFib or atrial fibrillation. The heart is divided into 4 chambers, 2 called atria and 2 called ventricles. And when the heart beats normally. There's a very nice rhythmic beating of the atria, which squeezes down, pushes blood into the next chamber. The ventricles squeeze down, push bloods out of the vessel, and it's a very coordinated movement. Atrial fibrillation is when the atria, instead of squeezing down on a nice regular basis, kind of squeezes down in a way that is uncoordinated and doesn't squeeze down completely, so that the blood which is trapped in the atria is much more likely to form a clot. And remember, we talked about the type of stroke where blood clot can go to the brain. When a person has atrial fibrillation, they can have a higher risk of these blood clots that are forming in the heart going to the brain. So if a person has atrial fibrillation, it's extremely important to manage that condition very carefully. So some of the ways in which that's managed is with blood thinners, or sometimes the atrial fibrillation itself can be reversed. Very important to get that taken care of correctly. Another, unfortunately, fairly common disease that people have in old age is called Alzheimer's disease. It's also called disease of the Alzheimer's type, in that Alzheimer's disease might possibly be more than one disease with final common pathways. But what we know about it at this point is that the risk for Alzheimer's disease does increase with age, but it's not normal with aging, because there's plenty of people who live to be in the extremes of old age without having Alzheimer's disease. In fact, it used to be called senility, which only means aging. It was so associated with aging that people thought aging and Alzheimer's disease and senility was all the same thing. We now understand that Alzheimer's disease is a disease and it's not inevitable. It's common, it's just not inevitable. Some of the things that happen with Alzheimer's disease can be seen in very tiny amounts in the brain with a brain biopsy, or after a person dies, looking at the brain in pathology slides. But it's so tiny it can't be seen at this time in any kind of imaging while a person is alive. And one of the things that happens is a deposition of amyloid in the brain tissue in the form of amyloid plaques. Those things just should not be there. There's been a lot of research trying to find ways to either prevent the deposition of amyloid in the brain or to try to eliminate it once it's there already. Another thing that happens in the brain pathology in Alzheimer's disease is something called neurofibrillary tangles. But one of the most interesting things that happens, remember I said that one neuron talks to another neuron by releasing neurochemicals, and they release it into a little space, tiny space between the first neuron and the second neuron, and it's the concentration of certain chemicals in this space or synapse that attaches to receptors on the downstream neuron that makes something happen. Well, it turns out that one of the most common problems with Alzheimer's type dementia is an increasing difficulty with making memory for new things, things that just happened. And one of the things that we know is that there's a neurochemical called acetylcholine, which is extremely interesting and important in allowing a person to develop a new memory. And it turns out that there's the cell bodies that make most of the brain's acetylcholine begin to degrade or shrink or die off in Alzheimer's disease. And as the brain of an Alzheimer's disease person has much less of this acetylcholine that it should have. And the problems with acetylcholine form the basis for most of the current medications that we currently are able to prescribe for people with Alzheimer's disease. Another way of looking at the brain of somebody with Alzheimer's disease is with a PET scan. And we usually don't need a PET scan to make a diagnosis of a person with Alzheimer's disease, because the person's symptoms and the way the symptoms came on and the cluster of behaviors that people have are usually enough for a person who's expert in Alzheimer's disease to make a diagnosis. But to make sure that we totally eliminate the notion that Alzheimer's disease is just normal aging, a group of researchers has been taking a look at PET scans, PET scans with aging, and these kinds of scans look at the function. It turns out if you were to look at the brain of a person with Alzheimer's disease with a CT scan that is just looking, or a CAT scan, that is just looking at the image of the brain, it might look fine. There might be some shrinking, but the shrinking is not really well correlated with the degree of the disease. However, when you take a look at a PET scan, the function of the brain, how well it's metabolizing various things like glucose, is going to be really different between the brain of somebody with Alzheimer's disease and a normal person without the disease at the same age. It's the difference between, if, let's say you had a car that wasn't working really well, it kept stalling out and it just, it's coughing and hiccuping, and you take it to a mechanic who opens the hood, looks at the motor and says, looks fine to me. You're saying, yeah, but it doesn't work very well. And that's the difference really between a CAT scan, which is looking at the image of the brain, and looking at a PET scan, which is showing you the function of the brain. So when you look at the PET scan, you really see that the way that the brain is functioning with Alzheimer's disease is very different. Those things that I showed you, for example, the plaques and the neurofibrillary tangles and the decline in acetylcholine is not something you can see with imaging. Those are the sort of things you see under a microscope. The CAT scan doesn't show you those things at all. The PET scan begins to show you there's a really big difference. So if we're taking a look at whether or not a person has Alzheimer's disease, we're looking at various things. We're looking at how did this start? And usually you talk about an insidious onset. In other words, nobody knows for sure when it started. People are looking at each other and saying, something wrong with mom, or something going wrong with dad. And they're kind of talking to each other and saying, I'm not sure. But last year at this time, they were a whole lot better functioning than they are now. So, but nobody can tell a date or an event when something happened, as opposed to a stroke. And a stroke, even if you don't know the person had a stroke, maybe they had one or a series of them, you usually can tell there was a sort of sudden decline in this person. But with an Alzheimer's type dementia, you really don't. It's more of an insidious onset. We do know that another thing with Alzheimer's disease, it's progressive. It doesn't start and then stop. It may plateau for a little while, but it keeps getting worse. That's what we call progression. The progression could be relatively slow or could be pretty fast, but there's still a progression. The earliest symptoms of a person with Alzheimer's type dementia tend to be decline in short-term memory, the memory for things that just happened. What did you have for breakfast today? What did you do yesterday? Again, looking at long-term memory, you might be able to talk at great length with this person with things that happened a long time ago and be very confused because they're not remembering what happened yesterday, but they can talk about something that happened 30 years ago. Again, retrieving an old memory, initially with Alzheimer's disease or an Alzheimer's type dementia, is much easier for them than making a new memory, laying down that new memory. Again, whether that's related to acetylcholine, very likely. There's also problems with orientation. Quite often a person is doing fine in very usual circumstances, their own home, how to get around in places with which they're very familiar. But there's also an orientation task. Remember we talked about one of the functions of the brain is orientation. And orienting yourself in a new place. You get off a plane, you land in an airport you've never been before. The job is to find your bags and get into a taxi and figuring out from the signs, where you're supposed to go. That's a fairly sophisticated task of orientation. A person with an Alzheimer's type dementia who used to be able to do that fine may find that they're really having a hard time with that, finding their way around someplace new. In fact, many physicians know that sometimes a person who's been on a trip and had difficulty on the trip first comes to see them with some questions about how is their brain functioning because they had a really hard time in unfamiliar surroundings. Another common problem with Alzheimer's type dementia is called a loss of executive functioning. Now, what the heck does that mean? A good executive is somebody who can assess a situation and then plan a course of action. Loss of executive function in people with Alzheimer's disease may be subtle at first and then gets much worse as the disease progresses, but they really have a hard time to assess their situation, to plan out what they want to do or what they need to do, and to carry something out. Loss of executive functioning. And that may display itself in many different ways. Now, the insidious onset, the progression, slow or rapid, short-term memory problems, loss of executive functioning, or difficulty with executive functioning, and problems with orientation are very common, almost universal in those people who have, unfortunately, who have an Alzheimer's type dementia. And however, other symptoms can also occur that are not universal. One of the things, for example, is a problem with language. Some people may have a real hard time finding the word for something, or may quite often call something by another name, and they have a really hard time with that. Sometimes people have very serious behavior problems or changes in personality. Maybe about a fourth of the people with Alzheimer's disease become very suspicious and paranoid of other people. That's unfortunately too common. And sometimes that types of behavior or accusations serve to distance themselves from other people just at the time when they need other people to come forward to help them and to recognize, wait a minute, this isn't normal dad, this is dad with a problem. And in the meantime, they may well push away people by virtue of accusing them of the craziest things, when indeed that's a disease talking, it's not them. Another common disease that occurs with aging, with increasing age, but actually can occur at much younger ages as well, is Parkinson's disease. If you remember when we talked about Alzheimer's disease being mainly a disease of the decline in a certain neurotransmitter called acetylcholine, and the problems that that decline causes, Parkinson's disease is analogous to Alzheimer's disease. It's not the same, it's a different disease, but again you see a cluster of certain types of cells that make a different neurotransmitter, a neurochemical called dopamine, and those cells begin to shrivel and decline and produce less of the brain's dopamine than it should. And dopamine is necessary in those tracts in the brain to help with coordinated movements. They have more difficulty with a number of things, mainly that relate to coordinated movement. If you take a look at each individual muscle that the person has, that muscle strength may be fine, but they have a lot of difficulty with coordinating those muscles so that they work well together. If you take a look at the slide where you have that black line, those are, it's called substantia nigra. That simply means black stuff or dark stuff in the brain. There's an area of the brain called the midbrain, and where the cell bodies accumulate or are mostly found that make dopamine in the brain begins to degenerate. A very interesting parallel, actually, or analogy to that of the degradation of cell bodies in certain other areas of the brain in Alzheimer's type disease. So let's take a look at some of the common symptoms in Parkinson's disease. The important thing with Parkinson's disease that's also analogous to certain functions that are lost in Alzheimer's disease is that not everyone has the same cluster of diseases. Usually there's this progressive loss of coordination of muscle movements. There might be muscle rigidity. You tend to see people walk sort of bent over and very rigid. They also may have a tremor. And not everybody with Parkinson's disease have a tremor. When those who do have the disease have a tremor, you know, a shake, quite often the disease is easier to diagnose. And it's called a resting tremor. That means when the hand, usually it's the hand, are resting, is when the tremor is worse. When they go to do something, to point something out, usually the tremor is much less noticeable. And sometimes people with a resting tremor, if they have learned that if they hold their hands together and squeeze a little bit, the tremor goes down. And you see quite often people with Parkinson's disease have learned to do that so that their tremor is less noticeable. One of the things about the symptoms, such as the tremor, is that, or muscle rigidity, can be that it's worse on one side of the body than the other. So it may be both sides of the body, or it may be just one. And sometimes when it's just one side of the body, it's a little bit more difficult to diagnose. Because there's a loss of coordinated muscle movement, one of the things that you tend to see in a person with Parkinson's disease who's walking is a loss of the arm swing. When we walk normally, we tend to swing our arms a little bit. And a person with Parkinson's disease might have lost that and just be tending to walk with their hands just down at their side. It's one of the ways in which, if you watch people walk, you can make a diagnosis of Parkinson's disease. If they lost that natural coordinated movement and loss of the arm swing. They may also have difficulty initiating movement. By that we mean if they go to start walking, if they're at a stop and they go to start walking, there may be a hesitation before they can take that first step. One of the problems that is fairly common in people with Parkinson's disease is difficulty swallowing. You wonder, why is that? Well, if you ever thought about how do we swallow something and get it from our mouth down to our stomach in the right direction, it turns out this is a very sophisticated series of muscle movements, one coordinated right after the other, so that you can swallow things so that you don't aspirate, doesn't get into your lungs by mistake, goes down into your stomach, and there's a whole series of muscle movements that take place to push the food down in the right direction. That's why with Parkinson's disease, loss of coordinated muscle movement, people might have a lot of trouble swallowing correctly, or might get things down the wrong way, or might end up coughing something out. And so it's a fairly typical, common problem with people who have Parkinson's disease. One thing that quite often people notice about somebody with Parkinson's disease is that their speech becomes much more quiet. It's not as loud as it used to be. They have much softer voice, and their handwriting, interestingly enough, can get smaller than it ordinarily is. Micrographia is what it's called. Now, if you know someone with Parkinson's disease, or let's say you know 3 people with Parkinson's disease, what's going to be common among the 3? Well, loss of coordinated muscle movement, but in a progression of disease, some rapid, some slower, and then a combination of some of these symptoms in some people but not in others, so that it may be difficult to diagnose if a person doesn't have a tremor. I myself have diagnosed many people with Parkinson's disease who did not have a tremor because the constellation of symptoms that they had, some people just thought, well, that's normal aging. And I just said, well, that's normal aging in a person with Parkinson's disease. And the way to find out for sure is that most people with Parkinson's disease do respond to Sinemet, a medication which is a combination of carbidopa and levodopa, and giving them a small amount to start with and watching to see if they get better is a very good diagnostic test, because that medication doesn't help anything but Parkinson's disease. But it's important to try to make this diagnosis if you can, because people can be helped so that they can live a much better life in proper treatment than they would if their condition was just allowed to get worse and worse and not be properly treated. But one of the things that I wanted to talk about is this bias that occurs in older people, in that if a person has problems with their ability to think clearly, sometimes people say, oh, that's senility, or that's normal aging, or what can you expect? And it turns out that quite often these conditions are those that can be reversed. If you get away from the bias of it's normal for older people to have serious problems with their ability to think and their ability to function, and begin to think, if they have problems with their ability to think clearly and to function, let's see if there's a possibility that some of this can be reversed. Perhaps what they have is a delirium. A delirium is a confusional state. If you think about it this way, suppose you had a very high fever and you just couldn't think clearly. That probably would not be the day that you would like to pay your bills or figure out your income tax. You're just not thinking clearly. Well, it turns out acute illness causes something called delirium. It's actually a shared experience. We've all been sick at some time and not been able to function as well as we could when we're well. And part of it is because your brain is not functioning correctly. Now, if you're 80 and you have this problem, somebody might say, oh gosh, they're getting Alzheimer's disease. Must be something wrong with that guy. They wouldn't be likely to say, what in the world is wrong with them? But if they're 18 and suddenly they don't function the way they should, somebody might say, I wonder if they're drinking. I wonder if they're taking medication. I wonder what's happening. I wonder if they're sick. You don't normally think that 18-year-old is going to have acute confusional state. But if they're 80, sometimes people don't look and they say, what do you expect at your age? And so you have to really look to see if the person isn't really suffering the effects of some illness where those problems can be reversed. One of the most common things that happens that causes a bit of delirium and confusional state in older people is medications. There are many, many medications that people take, whether they're prescribed medications, over-the-counter medications, sometimes herbal supplements, that can cause people to have a delirium or acute confusional state that can be reversed. For example, over-the-counter sleep medications are some of the worst ones. And sometimes people forget to tell their physician they're even taking these medications, so the physician is trying to figure out why the person's so confused, and it turns out it's the accumulated effect of other medications that the physician doesn't know the person's taking that is causing this. I've seen many older people who many people thought had Alzheimer's disease, and when I saw them and found out the medications they were taking, plus the medications that they were purchasing at the drugstore or pharmacy, or herbal supplements they were taking, and just get them off of everything that they don't absolutely need, then I find that quite often the person's mental status just cleared up over the course of a few weeks. It might take about 6 weeks or so, but that is very reassuring to know that many of these acute confusional states can be completely reversed. Another thing that can happen is that, let's say, remember we talked about how a person can take a bit of alcohol every day and it seems to be good for them. However, too much is not so good for you. It turns out that the same amount of alcohol that you may have always drank throughout your life as your adult life, and you're still drinking, may now in old age, because you don't have as much functional reserve in your body, don't clear it as well, it may be causing you to be more confused than the same amount would have caused you when you were younger. And that sometimes people don't understand. I've always had 1 Tom Collins or 2 Tom Collins every night before I went to bed, and it never caused me a problem before, so it can't be the alcohol, doc. Well, so I said, well, how about if we just, well, let's just do a test. Let's just say for the next 6 weeks, you don't have any alcohol at all, and see what happens to your mental status, see what clears up and what doesn't. People who ordinarily are willing to try that, you know, are willing to work with you. People who are not willing to stop all alcohol to get rid of an acquired confusional state are probably drinking more than what they told you they were drinking in the first place. And then you may have another problem on your hands, which is an alcohol dependence. But again, we're talking about something that's potentially reversible. Another common problem that can cause delirium or confusional states in older people is depression. Depression is altogether too common. However, it is eminently treatable. There are different types of depression, but rather than get into that, just the idea that a person who's not functioning the way that they should be able to function may be depressed. And there's different types of depression, so it may be very difficult to diagnose at first. So in summary, what we've talked about here are things that are normal with aging. A normal aging brain ought to work fine for the 100 years or so that we might want to use it. However, there are certain conditions that are common with age. Some of them are preventable now, such as various types of strokes. Some of them which are eminently treatable, such as Parkinson's disease, and probably not curable at this stage, but very treatable. And some where there's some early treatments, but where a lot more work needs to be done. But they're also not normal. These are accumulated diseases. And then there are some conditions that cause a decline in function in older people that are completely reversible. And those are those things that cause delirium or a depression that can be very well treated in old age. So in summary also what I would say is that when you take a look at aging, people don't age the same way. If you take a look at people who are all, let's say, 20 years old, no matter what you test in them, whatever functional ability that you want to test, they test pretty much like each other. If you take a bunch of people who are now 80 and you test them, they test very differently from each other. And the way in which they're alike is most likely accumulated aging. But the ways in which they're different tend to be the effects of disease. And some of that disease is treatable. So it's, the bottom line is not to assume that aging means infirmity. It doesn't. It means that we have a lot to work on and that people can be healthy as they get older. Again, I'm Dr. Pat Blanchette. Thank you for your time. I hope you found this interesting. Thank you.